Okay, ergonomics. I took this picture. I cover the residents at the Washington Hospital Center, and they're young, and they can do this. Is this sustainable? It is not sustainable. There is no way they're going to be able to do that for 30 years. Now, this is me taking out a lingually impacted distoangular bicuspid. These are the hardest of all. Third molars are easier than this because I can't whack these roots. Now, this is what I'm doing. I'm using the X-Guide with 3D vision. I'm looking at that screen. My staff's going to be looking over my shoulder at another screen. Okay, so I'm operating, and you can see I'm looking here. I found that thing with the X-Guide, and now I'm cutting with a piezo. So I can make this tiny incision, and I know if I touch the soft tissue, I'm not going to tear it apart with a rotary instrument. So this is where we can be. Look at me, I'm standing up. I could be sitting down. I like to stand sometimes, and sometimes I sit down. The best thing you can do is both. Okay? 75% of us are going to have some form of pain or disability from musculoskeletal, and it can be avoided if you stand up straight or sit down. Minimally invasive surgery. You cannot do minimally invasive surgery unless you guide. You risk bagging a nerve or sticking the implant through the side of a bone if you don't guide in some way. And we all know, even the patients know, minimally invasive surgery is better. Decrease mortality, improve results. So, why don't you guide every implant, every patient, every time? What is it? Training? Are you afraid? Change is difficult. So we studied that. This was Dr. Block's idea. Dr. Block is an OMS who's in charge of oral surgery for the United States at CE for our association. He's a brilliant guy. He was chairman at LSU for years, and now he's in private practice. And we tracked our first 10, our next 10, our next 10, and our last 10. And we looked at it. And our definition of proficiency is when there was no statistically significant difference, 0.05, between any of us. We all became the same. Now remember before I said, oh, you say I'm better than that guy. Well, you're not. But when will you be as good as us? After 10 to 20 implants. Implants, not cases. Somewhere between 10 and 20 implants, which isn't very many, you're going to be as good as me. Okay? At using that machine. That's all it takes. So I did a little study with dental students. These were implant naive. They had never placed an implant. And they did 20 cases freehand, and they could put the model. They planned all these cases on with a computer, and then I allowed them to take a caliper and figure out the positions, okay, and then drill. And then they did their next cases with dynamic guidance. Because they've been playing video games their whole life, okay? They live with, well, I'm starting to act like that now with cell phones in front of their eyes. They trip over things because they're walking like this down the street. Okay? God help them when they get older. There could be a lot of broken hips. Okay? So, the students were better than me after placing 20 implants guided. So it's not hard to learn. Now, is there a learning curve with static guides? There's mixed things in the literature, but there's more that say yes than there are that say no. And I'm going to show you why I know there's a learning curve when we look at why there's inaccuracies. So again, why aren't you guiding every implant, every patient, every time? If it's easy to learn and the evidence screams you should be guiding, it's the honest answer, it's time and cost. Static guides cost a lot, and they're a pain in the neck. The only reason that I did a ton of static guides is because I set up a business system in my office where my staff was doing everything. It was bam, 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 and that was hard to do. So really what's this? This is called usability in the engineering world, okay? The workflow. Look at the workflow for a static guide. You have to take an impression. That's either with an intraoral scanner or with regular impression techniques. You got to take a CBCT with fiducials in the mouth. You got to plan the case. You got to fabricate models in some systems and a guide, or models or a guide if you're going to make provisionals. And then you can go to surgery. If you're going to do it lab fabricated, it's going to take days. And if you're going to do it in your office, it takes hours, minimum 3 hours. And you can't change a plan. The reason guides don't fit is because people don't use intraoral scanners, just so you know. 10% of my guides used to not fit when I was doing this, and as soon as I got an intraoral scanner, they fit every time. Why is that? Because I'm a human. You introduce human element, and the efficiency and the accuracy goes down. So let's look at the usability or the workflow of dynamic navigation. You place your fiducials, and that step, by the way, will be going away. CBCT, you then plan, you calibrate, and you go to surgery. This takes less than 30 minutes, okay? It takes less than 30 minutes, and you can change anything, anytime in the middle of surgery. So you can do everything you're doing today efficiently, and you can be a better surgeon. So cost considerations for static guides. You have printers and milling machines if you do it in your office. You have the supplies, you have the tubes, the acrylic, the resin if you're printing them. And you have the proprietary drill sets, which are very expensive. And you have to change them. If you don't change your burrs regularly, and I'm going to show you why, you're going to get inaccurate. This I took off the internet. If you're doing at least two implants, a week, or you're doing pretty busy implant practice, you're going to need a robust printer. This will print 2 to 4 guides in 2 hours with a 1 hour cure afterwards, or 8 guides in 4 hours with a 1 hour cure. And it costs 15 grand. And if you divide it by the supplies they give you, that's $300 a case while you're paying for it, okay? While you're paying for it, capital costs. Afterwards, if this thing works and you don't have problems with it and you take away the capital costs, it's still about $150. And the drill sets are expensive, and you're supposed to change the drills after 15 osteotomies. A lot of people don't, but if you don't, you're going to be less accurate. Staff time, in my office, minimum $20 an hour, okay? This is what I used to do. I didn't think that it was a good idea for me to print this stuff, and I hate doing lab work, so I sent everything out. I personally never got a guide for less than about $370, and the patient has to pay for that. Now, how about x-nav or dynamic navigation? You got to buy the machine, you got to pay for the clip, and while you're paying for the whole system, your cases are going to, each case will cost you about $140. That's cheaper than sending stuff out for lab work if you're doing a non-CAD system, and I'll show you. So we did a study, used a couple offices. We used what I consider contemporary implant dentistry, every patient had a CBCT, and we were talking about tooth-supported guides, or tooth-supported guidance. We compared analog guide stents, which are the minimum standard, I think. That these are non-CAD, static CAD-CAM guides, and dynamic navigation. We used a staff time cost variable of $20 an hour, and then we used leasing, because most people lease in the United States, with a $1 buyout. So you're going to see the capital costs in here. So this is analog guides. I would send out because I hate doing lab work. They cost me about $200. This is a lab fabricated guide. Again, this is the way I did it. Somewhere between $300 and $1,000, and some of the new ones with the foundation guides are $3,000. And it took more than a day. You couldn't do it the same day. This is if you print it. It doesn't take 3 hours. It takes more than 3 hours. So you really can't do that in the same day. And this is dynamic navigation. It takes less than 30 minutes, and the costs are less than lab work. Remember, when you send stuff out, what does it cost to just take an intraoral impression? If you're using polyvinyl siloxane, it Costs you $30 just for the impression. What is your staff time worth? People forget these things. So you got to look at the whole picture. Dynamic navigation is the least expensive of all of them. So, eureka! Why don't you guide every patient, every implant, every time? You can. You can be more accurate and precise either way. Your ability to change your plan anytime, there's only one, dynamic navigation. Ergonomics, static guides are a pain in the neck. They're hard to put, especially in the back of the mouth. So dynamic navigation blows that away. Ease of training, they're both easy to learn. You take your time. Fabrication time, there isn't any. Costs, the costs are minimal. So, let's look at, since now we all agree you should be guiding your implants, at what makes these systems less accurate. Why is there inaccuracy in these systems? Any of them. You have intrinsic error, which is manufacturer controlled, and you have extrinsic error, which is process related. That's really about people. Okay? Now these are all the areas that are intrinsic that can mess you up. Static guides and dynamic navigation. Spatial resolution of your CT. When you're doing static guides, the manufacturers definitely know. That's why they make you send models and things that have been scanned by your CT scanner at the beginning, because they can look and see how accurate your CT scanner is, and they can make up for it. Image data processing, planning software, all these things. Guide fabrication. Anytime you make anything, you add inaccuracy. Guide tube are a big deal, and I'll show you why. Registration calibration errors are in both. Tracking errors are only dynamic, and hand pacing inaccuracy, which you probably have never thought about because you couldn't see it, is a problem with both. So, how accurate are your CT scanners? You don't know unless you look at them. This was a study done recently, okay? And it shows that CT scanner inaccuracy affects all kind of guidance, static and dynamic. So you really want to make sure your scanners are good. Now this is something you really won't think about. You think static guides are super accurate. Well, why aren't they? This was done again by Verkruzian, the periodontist in Belgium. And what he did is he measured the angular deviation and the positional deviation of a 13 millimeter implant. The prolongation is the difference between the bottom of the tube and the bone. And then they were either guide tubes that went, drills that went straight into the guide tubes, or handheld ones. Now, intuitively, you would think that this would be more accurate than that, but they're not. When you hold them, they're actually more accurate. So why is this? Let's take a look. This is a little video that I made of my guides in my office, okay? Now look here. Oops, shoot, let me go back. I meant to hit the laser there. So look right there. You're seeing the motion that they, and you can't even see it up. You see it moving around up here? Now imagine if you don't change your drills. Those things, anybody who's doing this sees the little pieces of metal that fall off when you use these things. When you get a brand new set, I had to lubricate them in order to get the drills to go through. They'd get stuck. So this is his data. Millimeter implants. Shoulder deviation, 1.3. Implant apex, 2.4. Angular. Remember the studies I showed you, Verkruzian studies? These numbers are in his edentulous. That's where it is, the tubes. Now forget about the flex between the tubes and the plastic and when they break. This is the primary area, but there's all sorts of other areas that go wrong. Now this is something that nobody's reported, and we saw it because we could see it with the X guide. When you put a drill into a drill chuck, there's bearings in there so it'll spin. And if anybody knows anything about engineering, the more accurate your bearings are, the more expensive they are to make. Okay? So there has to be some slop in the systems. This is with a 15 millimeter implant. there's about 400 microns of slop in there. And when you try this out by hand, I can show you where it shows up. Okay? Now, when you add a drill extension on there, there's a millimeter to 1.25. This affects both static and dynamic guides. Nobody's ever talked about this stuff. Nobody thought about it because you couldn't see it. I never saw it. We didn't know it existed. When we start registering edentulous patients, we wanted to just use the drill, but we can't because every time we use it, we introduce 400 microns of inaccuracy. We had to make a rigid system. This is with a drill extension. See? It's about almost millimeter and a half. So this is where a lot of your inaccuracy is coming from. So I just don't, if I can help it, I don't ever use a drill extension because it's bending like crazy. So I try to use these drills that are around 30 to 40 millimeters in length. And anytime I have a system like this, Zimmer, that has these short drills and the top of the drill hits the adjacent teeth, I'll go over to these rather than use these drill extensions if I can help it. Okay? So the drill length makes a difference. Human error is a big deal in everything we do. The biggest problem with anything is human error. We are the biggest problem. In all the different industries, human error is responsible for most of the mistakes. And that's extrinsic error. These are all the steps, impressions, models, CT protocols, and I'm going to show you little things as we go along today that when you take a CT that matter, like using a cotton roll. Okay? Image guide fabrications, you have to do something. Tracker fabrication, provisional fabrications, seating and movement of the guides, seating and movement of the trackers. All these things are human. So when you look at all the studies, this is from Jung's meta-analysis, when you look at the standard deviations of the humans, they go bigger, they go up. It's the patient and the doctor. So, how do you become precise and accurate and efficient? You remove as much of the human element as you can. You go digital, because digital allows us to make fewer things. Okay? And we want an easy, small workflow. The shorter the workflow, the easier the usability, the more likely you're going to use it. Now, these are pictures of my patients. This is my stuff. You know, I'm seating this guide in a mucosally supported case. And this is early on, I was using screws, and the screws bend the guides. This is a picture that I show of a tube coming loose. Okay? And then a crack. There's a crack down here. This is the biggest problem with static guides. You can't get them in patients' mouths. They can't open wide enough. Now they have tubes that open in the side, but what does that do to the accuracy? It goes down. This is the thing you have to learn when you're using a dynamic navigation is keep your staff's head out of the way. Okay? And then you have to learn to work around the guides. This is the hardest thing to do. If you if you sit at 9 o'clock or stand at 9 o'clock and you're working on the other side, you have to learn to keep your hands out of the way of the tracking arrays. And you can see these are the two tracking views. You can see how my hands are around there. And I'm using a double finger rest because I'm working in microns. I can see my hands shake. I can see drills bend. I can see chucks, 400 microns of chuck. So my hands, as I've gotten older, I need to use double finger rest. That's me, okay? You have to learn how to tweak these tracking arrays because everything's keyed around this. This is the dynamic reference frame, and I'm going to teach you how to do that. So summary of the challenges. Static guides, these are visualization and patient related. Seating the guides, static is a problem. Visualization, instrument guide damage, static is a problem. Optical interference, dynamic. Patient related, loose guides, loose arrays, both. Limited mouth opening, this means you can't use them in the back of the mouth. What you can do is stick the drill in ahead of time, then put it in the mouth if it's short enough. We all have done that. And then you can't even use the systems with some size drills, and you can't get them close enough to adjacent teeth sometimes because of the tubes. So, this is important. Remember I told you it's not just for implants? This is just not for implants. look at all the things you can do with dynamic. Minimal mouth opening. I have a lot of patients coming in now because they know the rheumatologists send me scleroderma and rheumatoid arthritic patients, radiated patients from the oncologist. Foreign bodies, screws and failed implants. I can go find things. Osseodensification is a big deal. I'm going to talk to you about that. Sinus elevations with osseodensification. You can't use this with a static guide. Root shields, very cool. Ridge splitting, harvesting grafts, placing bone rings, big deal. Distraction osteogenesis, nerve transpositions, all with dynamic guidance. Deep bone biopsies for the OMSs. Extractions are giant. We're getting there. Excision of tori, apicos. Endo is giant. I'm stunned at how fast the endodontists are using this. Microendoaxis. This could revolutionize endodontics. So how do you start? I hope I've convinced you should be guiding. You should start with easy cases. Easy cases. Don't go and say, oh, I'm only going to use this for the big cases. Well, then you're going to get frustrated because you're not going to know how to do it. And the other thing is your team isn't going to know how to do it. You want to start easy. Your first 20 cases should be easy cases that you'd say in the past I shouldn't guide. Well, now you know you should guide every case. So start easy. And then afterwards, Dr. Block got up in front of all oral surgeons and said, you know, there's an ethical issue. Before we didn't know how good we were. Because of Vercruzian and us, we know how good we are. I don't care who you are. You're probably not better than all those master surgeons. You can be just as good. So ethically, we're not going to talk legal terms. Let's talk about ethics. Do no harm. Every patient, every implant, every time is really what you should be doing. So, all guided surgery is more accurate, precise than freehand. Dynamic navigation is efficient and flexible. So if you have static guides, you can guide with them. But if you want to be efficient and use it for a lot of things, you want dynamic navigation. So, you are only as good as what you can see. Okay? So treatment planning is a big deal. What we find when people start guiding is surgeons realize they're not very good at treatment planning because they've never seen their plan executed instantly. And so you plan your case and you look and you go around and you go, do I like that plan? And then what happens is parallax sets in and you don't believe your plan. And you got to go back and check. So you really need to be able to image your cases and plan well. And there's different ways of getting your images in. You can do a CT alone, you can do CT with an imaging guide, and you can use CT with STL superimposition because you need to be doing top-down dentistry. So CT alone are good for one or two teeth when you have mesial and distal abutments because then you can use the adjacent teeth for occlusion. They're good for young patients because there's not a lot of artifact and because they don't have a lot of restorations. And when you can use virtual teeth, they're okay. This is the easiest way. What are the disadvantages? I would never do this for an aesthetic case. I will always get an STL. Artifacts in old patients, you can't even see anything with a CT alone. Occlusion, you can't see occlusion with a CT alone because you have to open the mouth. Otherwise, you can't see the occlusal surfaces. And you can't visualize real detail because it's 200 microns of resolution. So, the advantages of a CT with an imaging guide is you can visualize soft and hard tissue, you can visualize occlusion, and you don't need to use an intraoral scanner if you don't want to buy one. But you got to do lab work. And sometimes they get in the way of the X-clips because you can't have an X-clip and an imaging guide in the same place because imaging guides move and an X-clip needs to be rigid. So this is a case of Dr. Progobin's. He likes to use imaging guides. He does a diagnose up. He gives his orthodontist a appropriately sized denture tooth and says, make it this big because not every orthodontist is the same. And he uses it to fabricate the imaging guide. Essex type are really great because they're easy to make and you can make them as rigid as the plastic thickness. And they need to be stable, but you've got to cut them away from wherever you're going to put your X-clip. So these are different ways of making imaging guides. These are, again, Dr. Hogeman's images. He does a full contour wax up. He does a silicone matrix. And this is something that I made him do over the years. Separate, you've got to see contacts. You put these things on a CT and it's just a blur, it's a blob. So you've got to exaggerate your contacts. You've got to do lab work, though. I hate lab work. Not everybody sends me these things. And the X-clip gets in the way of using these sometimes, especially in bilateral cases. This is an old case that I did with an atomage, and you can see because those exaggerations with the contacts aren't in the right place, I really still have to guess where I'm going to put it. Okay? So you've got to watch when you do these that you make them really accurately. You can get pre-made radiopaque teeth. Ivoclar makes them. A radiopaque acrylic, or you can mix it yourself. This tends to be a little blobby. You know, it's not as nice. Now, this is something that I want you to try to get your head wrapped around. This is a full arch case, and you're going to see this case later. I'm going to be taking on and off temps because it's serial, so I'm going to be changing things as I go along. And I'd rather use an X-clip. So this is this is not Progovin's case. This is Dr. Dan Sullivan's case. I know he's got a couple of friends here. He's a prosthodontist in D.C. And this is the patient's provisionals, right? Full arch provisionals. And he duped them, and he put radiopaque acrylic in it. I put the X-clip on it. Now, this is about X-clips. If you put them on acrylic, they bond to it. You can't get them off. The only thing that will make them not stick is topical anesthetic. Don't use Vaseline. You can't put separating medium in a patient. I tried everything. We tried everything. Topical works great. Topical will do it. So if you want to keep an X-clip from bonding to provisionals, put topical all over the provisionals, put it on and pull it off. Don't leave it on there long or it'll bond to it. You only do that once. And my learning curve is really steep. I've done everything. So this is important. You need to understand. STL files are a surface. They're not a volume. So if you take an STL file of an Essex, the thickness of the plastic is in there. So when you superimpose them, it'll be hard to register the two. And I'll show you how to get around that. They're very accurate. STLs are around 25 microns. They are huge advantages. You can see hard and soft tissue. You can see occlusion. You don't need to use lab work. The X-clips don't interfere. You can use any restoration. You can use a fixed, an Essex, a flipper, partial denture, anything. And you can use virtual teeth with them. There's ways of obtaining STL files. Intraoral scanner is the easiest. You can take impressions and send it to the lab, and the lab can scan it for you. You can take a CBCT of a model and convert it to an STL, and there's software in the X-Guide to do that, so you don't have to buy extra software. And dual scan techniques for dentures, and I'll show you that later. Intraoral scanners, I think, are the most convenient. Lab scanners, if you want to send it to the lab, you don't want to buy an intraoral scanner. And this is what I was telling you about when you use Essex. Before you take the CT with it, this is a lot of patients come in with Invisalign retainers with teeth in them, and I don't want to wreck them to take the CT or an X-clip. I can't chop them up because then the patient has to pay for a new set. So I put some seating windows in them, at least 3 of them, on cusp tips. So now the cusp tip is sticking through during the CT. Okay? And then if you did take an impression with them, and you pour a model up, you're going to see the cusp tips coming through, and that's where you're going to superimpose. And I'll show you that in a second. So when I'm superimposing on the X-Guide software, I find those spots, and I touch them on the CT, and then I touch them on the STL file. And bam. Only need 3 points. Otherwise, the surface here would not eat the surface there because you got the thickness of the plastic. Does everybody understand that? That's important. If docs want to do wax-ups, I love wax-ups, okay? They just send me the wax-ups and I'll scan them for them. These are great. You can either send it to the lab or you can scan it in your own office. This is the same case, and that's the intraoral scan. I scanned that with my iTero scanner. And again, at the bottom here, I scanned it. Same case. This is old. I didn't place these. These were placed 20 years ago, and these are the x-nav placed. So, using a CBCT with a model. So if you don't have an intraoral scanner today, you can get STL files. Take an impression. You say you're using an Essex. Essex, when you scan them, sometimes they don't want to scan because the light bounces off of them. Okay, you can either sandblast them, or you can take the powder and spray it on there. They say you can use toothpaste. It doesn't work. So if you have an Essex, or you don't have an intraoral scanner, you take and put the appliance in the mouth, take the impression, pour the model, take a CBCT of the model, import the CT into the software, create an STL file by exporting the CT as a bone mesh, and I'll show you that, and then use that STL of the model and superimpose it on the patient. So here we are. We've imported the CBCT, or the DICOM file of the model. We map the arch, okay? And then we go up to File, and it says Export, and you click Export as a bone mesh, and it exports that DICOM as an STL. So you don't have to go get software to do it. It's in the machine, okay? Dual scan is what we all use for edentulous. And edentulous is great on this machine, okay? And dual scan is the easiest way of doing it. You put 5 to 7 sticky fiducials on the denture. You CBCT the denture itself. You do a CBC of the patient with those sticky fiducials in the denture. You import the CT of the patient. You then import a CTT of the denture. The software automatically converts that DICOM into an STL and superimposes it for you. So there you are. We've scanned that with the scanner. Then we put it in the patient's mouth and we scan the patient. Then we import the patient scan. And then on the screen, that's for importing the denture. You then tell the software which arch it is, and then the software automatically converts that DICOM to an STL and superimposes it for you. And there you go, bango. You're ready to plan. So you didn't have to make a scanning appliance. You're saving money, you're saving time. Here's some treatment planning pearls before we take a break. Treatment planning pearls. Take an intraoral scan or an impression before you pull the tooth. It's good for 2 things. It's your virtual plan when you go back, if you delay, and you can send it to the lab to make your provisional. Now, I don't like doing lab work, so the minute my patient knows I'm going to be pulling a tooth, they scan the patient. And I get a perfect record of the occlusion. And I don't have to do any virtual teeth. Okay? So I do this all the time. When you're using virtual teeth and you have an intraoral scanner, you can use virtual teeth because you can use the occlusion. It's easy. You have the occlusion to plan. You can use the contralateral teeth, and you make a virtual tooth on the contralateral to see the size of the natural tooth if it was missing when the patient came in, and then you duplicate it on this side. Because you have occlusion, you can use virtual teeth. If you don't have occlusion, you can't use virtual teeth. You're guessing. I don't guess. When you're planning, and you really don't think about this until you see it happen in front of your eyes, if you can, use the anatomy to your advantage. Don't try to drill into the cortical plate if you don't have to, because you're just going to fight it the whole time. And the same thing happens with static guides. When you get good at them, you realize you've got to try to treatment plan around these. You want to use it to your advantage to guide your implant. This is especially true with tapered implants and aggressive threads, because the threads are smaller or bigger than the osteotomy of the drills, and so when you put them in, it pushes it from hard surfaces to loose surfaces and displaces your implants. Cortical plates will displace tapered implants, and it's a big deal when you're doing bone grafts. So you see right down that corner there, it's going to push the tip that way. And you have to be careful of that, or when you're drilling, you feel it and you can then see it in the windows, and you're going to have to drill longer. So look at these things and take them into consideration when you're doing your plans. Now, one of the things we realized right away, everybody thinks depth is the big deal. Depth is the hardest to predict, because what is depth really determined by most of the time? It's not a nerve. It's the soft tissue. Every one of the periodontists is keyed into it. Not every oral surgeon is keyed into soft tissue. But when you're doing an aesthetic case, where do you want your platform relative to your buccal soft tissue margin? 3 to 4 millimeters, right? Every one of them. Somewhere, you don't want it too deep, you don't want it too shallow. So when do you make your determination? This is why static guides are a pain. You do it clinically. So you do your plan as best you can, and then you use this tool, which is in the tracking window, to move your implant up or down up to 2 millimeters without leaving the field. So you can change your depth. You can stick an analog in just like you do today, look at it, and say, oh, I want to tweak it 0.5 millimeter. And then you take press the button, move it up or down 0.5 millimeter. And you don't need to look at the patient while you're drilling. This can't be overemphasized, but you're still going to doubt yourself. Believe your plan. You've been working in a parallax world. And when you start planning in 3 dimensions, you're going to put an implant in and you go, it just happened to me last Friday. I put this implant in. Okay, now look where my plan is. It's right here because there's a defect here that I guided. I fixed this. And so I'm planning to this mesial margin, and it's 3 millimeters deep on the distal. So that was my plan. And then I put it in, and I look, and I go, oh my God, I put it in too deep. And then I go back, and I look at my plan, and I go, that's exactly where I planned it. I didn't believe my plan, so I went back and I looked at it. When you do complicated cases, you're going to use your parallax vision. You're going to go, God, that's the wrong place. And you're going to ham and haw when you first start. You're not going to believe the system. But I'm going to tell you, the system works. It works. It's engineered. The problem is us, okay, and our plans. Now, the cool thing is you can tweak your plan anytime. You don't like it. You know, you get a probe and say, you're too shallow. I planned at 3, it's only 2. You can drop it down with that tool I showed you. So you have to learn to believe your plan, because you've never done this before. You've used inefficient, incorrect parallax vision to do your surgery. And when you start seeing things appropriately, it's going to blow your mind and you're not going to believe it. Questions? Break? Are there any questions?